short review about the common side effects or complications from botulinum toxin injections and how can we manage them. So what are the common causes of common pitfalls? Either asymmetric injection points, meaning asymmetry leading to one eyebrow, for example, higher than the other, or getting too close to a muscle that should be avoided, or getting too far from a muscle that we're targeting, or using generic products that could cause hypersensitivity reactions. So symmetry is very important because the injector's eye is not a precise measuring tool, and placing the injection points at areas that are not very symmetric could lead to unnatural appearance. We've published our technique using a geometric measuring method to avoid such pitfalls. I'll start with the upper face with the glabellar lines. These are the common injection points at the procedures, the head of the corrugators, and sometimes we add 2 additional points at the... Why do we get ptosis? It's either that we go too high, so we catch the lower fibers of the frontalis muscles. If this happens, we find that the medial eyebrow dips down because we relaxed its elevator. On the other hand, if we go too low and the diffusion occurs to the eyelid levator, the levator palpebrae superioris, then we will get eyelid ptosis, which is much more difficult to manage. The forehead complications are mainly asymmetry, like the Mephisto sign or the elevation of the lateral eyebrows, brow ptosis or brow asymmetry, and celebrities are not immune to such complications. So how can we avoid such pitfalls? If we inject too low, as mentioned before, then we get the lower frontalis elevating the eyebrows and we get eyebrow ptosis. And if we inject too medial, leaving the lateral part of the frontalis muscle, it would compensate and contract to lift the lateral eyebrow, and we get the Mephisto sign. So to avoid it, we need to measure the full forehead and inject from temporal fusion line to temporal fusion line, making sure we're getting the full frontalis if we don't want a lateral eyebrow elevation. And we keep a safety distance by measuring the distance from our injection points to the eyebrow. Usually 2 centimeters are enough, but I always stick to 2.5 centimeters. The dotted lines down there are the depressor, are the points where we inject if we need to elevate the eyebrows or the medial eyebrow. So this is how we do it. I use a measuring tape, disposable one, and take the measurements. If we stop at this point, the medial, of the eyelid of the eye, at the iris, then we will get compensation by elevation of the lateral eyebrows. If we need to lift the eyebrow, then we will add 2 additional points, 3 to 5 units down there, and 3 units at the lateral orbicularis oculi muscle. These are the medial fibers of the orbicularis oculi muscle. Some people refer to it as a separate muscle, as the depressor supercilii, and other workers suggest that it is only the medial fibers of the depressor of the orbicularis oculi. Whatever it is, it would lift the medial eyebrow if we do inject it. So this white point is at the depressor supercilii. It would lift the medial eyebrow. Again here, we're correcting an asymmetric descent of the medial eyebrow, injecting the depressor supercilii muscle. If we have remaining remaining wrinkles, because we missed some of the lateral fibers of the frontalis muscle, we can correct it by injecting 1 or 2 units above this fold. And if we need to lift the lateral eyebrow, then we inject the superior lateral fibers of the orbicularis oculi muscle. I just grab the lateral part like a sandwich, the lateral part of the eyebrow, and I inject 2 to 5 units in this area. Regarding the orbicularis oculi injections, mainly for lateral canthal lines or crow's feet, if we inject the medial fibers of the orbicularis oculi, we will lift the medial eyebrow. If we inject the lateral fibers, then we will treat the crow's feet or the lateral canthal lines, and we could also lift the lateral eyebrow. The main side effects are a frozen or an unnatural look, which gives an impression that you're not really smiling from the heart, that people will not trust you. A chipmunk smile where only your cheeks move when you smile and you look like a chipmunk. And diplopia, if you reach the rectus muscles. The scleral show is like a staring look that patients do not appreciate. And skin laxity under the eyes in elderly patients. So this is an area that I inject only in young patients. Okay. So this are some examples of a chipmunk look and the scleral show. Double vision is very annoying, of course, and it's mainly when we inject beneath the eye and we get the inferior oblique muscles. But injecting any rectus muscle would make us, when we look to the side, one muscle would move faster than the other, or one eye would move faster than the other, so we get this blurring of vision, which is terribly annoying, but resolves spontaneously. If we get remaining lines, usually you get them at the lateral eyebrow, then we will need to inject those fibers of the orbicularis oculi muscle. We need to avoid the zygomaticus major and minor, so we don't go too lateral or too low, to avoid the drooping of the angle of the mouth. And to prevent, I just ask the patient to smile maximally and measure 2 centimeters from the lateral canthus, and I don't go any medial to a line drawn vertically along the lateral canthal line. Usually treatment here is watchful waiting, and the problem resolves within 4 to 6 weeks when the orbicularis oculi muscle starts regaining some of its function. So I think for the sake of time, I will not go through the pitfalls about the injections of the neck and the lower face.